Let me first thank everybody for being here today. I'm Hope Arthur. I'm the Executive Director of Workforce Innovation for the Health Collaborative in the Greater Cincinnati region. And I am so honored to be part of the group who is convening these meetings to bring together statewide healthcare education and workforce leaders like yourself to see how we can work together to increase the healthcare pathway, healthcare education pathway. We have four real modes that we've been focusing on. One is sharing innovative practices. Second is regional and statewide collaboration. The third is advocacy for smarter regulations. And the fourth is pursuing resources. Before I get started, I want to ask that you please take a moment and enter your name and organization into the chat. And we'll be making sure that we've got your information into our distribution list so that you'll receive updates and invites for future meetings from us. I also want to take this moment to remind you, if you have not done so already, to please join our new Mobilize platform. This is an online communication platform where we're collecting resources to help build out the information we're able to share with each other, as well as to help members of this group to connect with each other, ask questions, share best practices and such. And Michelle will be dropping the registration link into Mobilize. It's very easy to join. Simply click on the link she puts in the chat and you'll be able to provide just a little bit of information to submit your registration. Now, on to today's agenda. We have a fabulous agenda today. First, you're going to hear from one of our partners at Cincinnati State who has built great success with employers who are interested in his respiratory care program and how he helps them to have very successful incumbent worker training. And then next, we have one of our partners here from the Ohio Healthcare Association who will be sharing information about advocacy, both what they are doing as far as healthcare advocacy, as well as ways that we're recommending we start advocating to CMS, make the STNA instructor requirements change that we think will make it much more appropriate for instructors for that vital pathway program. Then finally, we'll conclude with Dr. Sarah DeLong, the Associate Director of Healthcare Programs at Butler Tech, facilitating a group discussion. We're very interested to hear about your current and your aspirational advocacy efforts and how you see they could better improve our healthcare workforce. Now it's my pleasure to formally introduce you to Mike Cheney. I've known Mike for years now. He's the program director at Cincinnati State, their consortium respiratory care program that also includes UC Claremont, one of our regional campuses. Mike has been a respiratory therapist for 30 years and still works one day a week at the hospital as staff RT. He's been at Cincinnati State for 28 years, full-time since 2005, and the program director since 2016. And as I said, Mike will be sharing insights gained from successfully collaborating with local employers to provide their incumbent workers with the best tools to succeed in his RT program. Mike, take it away.
All right, Hope, thanks for having me. And so I wanted to start off by just saying, kind of setting up what this program is. As you know, a lot of our health programs or health professions are in very high demand because of lots of reasons: baby boomers retiring, leaving the workforce, needing care. And so the employers have gotten creative in saying, hey, well, let's keep our people here, our incumbent workers, and we'll just pay their way through school as a way to fill these positions. Because raising pay, which a lot of them are doing that too, it's kind of like a pay war, which is great for the profession. But in addition to that, they've been, trying to retain their employees by paying their way through college. So let me introduce really quick what we tried many years ago. We did we had this what was called the Health Careers Collaborative. And what it was the health programs would hold spots for workers of our regional clinical employers, hospital employers and things like that. And so what we did is we held a certain number of spots. I think it was a little different maybe for each program. My program, I held 5 spots. And for employees of a specific, hospital. And we did this division wide. And what we found was we did 17 cohorts that I know of. And they called it a cohort because they would put their workers through as a cohort. The idea was to have them, people who knew each other, kind of go through as this learning community, and they would all get advised very much the same. Here's the courses you take this semester, and the idea was to just kind of go through the whole program together. But the challenges to that, and where it kind of broke down, was not everybody requires the same schedule, and not everybody had the same success rate in the pre-technical courses. So the cohort model kind of fell apart in terms of students going through together, because if somebody didn't pass one of their prerequisites or a non-technical course, they would have to take a different pathway. Also add to that, there was a certain work requirement, and a lot of these incumbent workers are lower income, and a lot of them have kids. They have to work a lot of responsibilities. They need insurance. And so statistically speaking, it did not work. Like I said, we did 17 cohorts, and our retention rate was for those people in the Health Careers Collaborative, it was not high at all. It was, for my program, it was anywhere from a half to a third of the mainstream people that went through. So, and I looked at the data for the entire division and found similar. A lot of years we had nobody pass. And so we kind of disbanded that. I think I was the first one to say, I can't do this anymore, because our success numbers were really failing, and because of that. And so I stopped holding the spots, and I didn't really, think it was real fair anyway, because we have, we're holding spots that could be held by other people. And so kind of went away for a few years. And then I was approached by a local hospital, and they wanted to revive it for their hospital. And so they wanted to be a feeder for the program. So they said, hey, you hold this number of spots, and we're going to, because we're feeding your program, we'd like reduced tuition rate. And I know there's a lot of this going on right now, not even at our college, but other colleges, where these programs are being approached by employers, offering to be a feeder if you hold spots, and, tuition deals and things like that. And so I'm just speaking for my program. So what happened was, and they had referenced the success of the Health Careers Collaborative. And so we looked at the data and, said, hey, here's kind of how this is laid out, and here's why. So if you really want to spend your money well, because they're offering to pay tuition as well, then there's some things we learned from the Health Careers Collaborative. So we sat down, we had several meetings, and they listened, and it's become a real success. So I'm going to share with you kind of what we've learned for what to do and what not to do to be successful in this. And if you have some model that was like our Health Careers Collaborative and it works for you, that's great. I'm not here to say that this is the only way to do it. This is just what worked and what didn't work for us. But as you know, every college is different. Every student population is different. So as far as the dedicated spots, that one I wasn't willing to do, because It sounds good on a business from a business perspective because you've got these feeders into your program, but you're at least in a competitive admission program like ours, they're being ranked differently than the other students, and they're not into the mix of the mainstream. So you lose that competitiveness, which gets you the better students. And the competitive part is important because it's less about getting students in, it's more about them graduating. I mean, it's kind of the point, is to get them out of the program. And if you're holding spots and they're not making it, then it's a waste of time and resources for everyone. So we got rid of and I said we need to get rid of the cohort model, where you're going to do one size fits all advising and all these students go through. So what we did was I said, hey, if you have a worker that is interested, they can contact me directly, or if it's another program, it could be a different, the advisor for that program. And let's do individual advising for them. Let's look at their story, what their work schedules like, what their, do they have, are they single parent, and kind of map out a plan pre-tech that fits them. And that then will increase the success rate, because you're not just kind of herding everybody through the same way. So we did that, and huge success. So for me, these workers of our local employers that are getting tuition paid, they're just like any other student. So their success rates have gone way up. In fact, they're, it was like a third to a half, or, it depends on what year you're looking at, of the mainstream. And now it's all the same. So the employers that are paying tuition, their money is very well spent because they're having successful employees come through. Lower tuition rate, that didn't happen. That's above my pay grade. And so that's a deal that, if you're thinking about doing this, you can tailor that to your own. And then I asked that it not be called a cohort, because it's really, which they still call it a cohort. And I just have to do a lot of explaining up front here. The students will go, oh, I'm in this cohort. And they think that they're going to do clinicals at their hospital with their coworkers, and they're going to go through being ranked separately. And I get it. It's, it's the idea of the cohort. But so I just tell them, hey, you're a regular student on my side. They're just paying for it. And the simplicity of it works so well. So what we do is I have a contact with that local employer. And actually, we're doing this with a couple hospitals now. But the one I'm referencing, I have a contact there. And every year when I accept students, we compare lists so they know who they're paying for and that they're legitimately in the program, accepted into the technical portion. And that way I know that they've talked to the employer as well. So we work really nicely together. We also do information sessions, which, the employers, they can email blast their whole institution with what this is. And then if I hold an information session, and the first one I did, I think I did 2 in one day, and we figured I talked to 450 workers. I went on their campus. And that was good because it kind of made people, I gave information to a lot of people. So they, some of them said, well, this isn't a good fit for me, or, I'm not interested. But a lot of them, it sparked their interest. And then they made an appointment with me, and we met. And like I said, it's been a huge success. And then, the last thing was the work hours. So what I tried to get them to do was, because people that try to work full time and go through a rigorous program, it just doesn't work statistically. I lose most of my full-time workers. So I told this particular employer, well, it would be great if you actually paid for them, let them stay on the clock while they're in class. which I didn't get that, but the work requirement that they made for their workers to be eligible went down by a lot. So now I have people who are not working as much. They're retaining benefits, going through and being successful. And to me, that's kind of the whole point. So did anybody have questions about anything, comments? Have you tried something similar that worked or didn't work?
I'll say I had the pleasure of being in the room with Mike when we went back to the one local employer to talk about all their wants and what was practical and effective. And the thing that most impressed me was how Mike was able to say no with such grace and data that the employer truly couldn't argue that he was working in their best interest. And I know often employers have a lot of asks of educators, and that educators often know what's really best. I don't know I've ever seen it done that well. It was impressive, truly impressive.
Well, thank you, Hope. And
So
you know,
I just have a question to clarify, just for my own mind. So you went to a specific employer, a specific healthcare provider, and put up this offer to those employees per this employer to come into this program, and that the employer would pay for their tuition and would give them some concession with their job, their workload. Is that, and it wasn't like on the outside community, but it was just within this specific program?
So this particular hospital that I'm talking about, they actually approached me because I didn't want any part of rebirth of something that's going to hurt our, success rates. And they came to me with, here's what we want. And I said, well, if we're going to do this, let's do it right. Because like I said, ultimately it's the student that you want to be successful. So I said, here's the things that I learned that worked and what didn't work. And they listened and they implemented most of what we talked about, and it's worked really well. So they came to me, and I've been approached by a couple other employers. We've reproduced this model for my program a few times now.
Oh, that's wonderful. Congratulations. Sounds like
Thank you.
Great.
Yeah, and the best part about it is there's nothing magic about it. It's I'm treating you like a regular student. To me, that's more equitable because, if I'm all about looking at what makes students successful, because that's kind of the point, and where somebody works doesn't lend to success. And so I don't want people in the program just because they work somewhere and bumping out maybe a single mom who's struggling and wants to provide a better life for their kid, or somebody that's lost their job, second career. It puts everybody on an equal playing field. But yeah, this is a great way for employers to retain workers and fill some of their higher level positions.
Hi, Mike. This is Kim Campbell from Nationwide Children's Hospital.
Hi, Kim.
Hi, I'm a former respiratory therapist, not working
okay.
by choice,
Okay.
but I am recruiting individuals in the organization, not only for respiratory, but pharmacy tech, LPN, and so forth. One of the challenges that I find is that there's lots of interest, but it's the math and science, all those prerequisite courses that students stumble. And did I understand you to say that there was a pre-plan that you had for students? Because what we're trying to discern is if we need to sort of ease folks into going into any of these areas, because they all are going to need that math and science regardless.
Mm-hmm. Yeah.
And it gets a little difficult and then people back away.
Yeah, so that's where the cohort didn't work, because they put everybody in at the same entry point. When I talk to a student, that they might say, I haven't had any math since high school. I really struggle. Then I know to back them up a little further in math, maybe, than somebody who says, man, I got I'm a whiz at math, and we can, start them a little later. But yeah, it's that way you have a start point and a pace that allows them to ease into it, because you're exactly right. They're so scared of math and science, and that way they can kind of take the prereqs that they need at the pace they need during pre-tech. And in terms of employer payment, I know that a lot of people are going to start into it and drop out because of what you're saying. And so what we decided was, in our discussions, was they would do regular tuition reimbursement until they were accepted into the technical portion of the respiratory program. And at that point, the employer knows that they have an invested, likely successful employee, and then they prepay up front.
That sounds great. Thank you so much.
Yeah.
And I hate to cut Mike off because he's a wealth of information. We endearingly call this effort the Cheney method because it's applied across many different areas at this point. If you have more questions for Mike, please feel free to enter them into chat. And Mike, if you would do us the honor of keeping an eye on what you might be able to respond to that way, that would be great.
I'm happy to. And people can contact me directly too if you want. I'll put my contact in there.
Thank you.
Thanks for having me.
Thanks for sharing this expertise. It's incredible work you do.
Thank you.
Now, please allow me to introduce you to Erin Hart. She is the Strategy Director for Ohio Healthcare Association, and she has also been a phenomenal partner to our organization. She has been working, providing advocacy for 4 years and specializes in policy and government relations in workforce development. Erin, again, is here to provide background on OCA, as well as how they can help organizations like ours. So without further ado, Erin, please take it away.
Thank you so much for that introduction. You can go ahead and move on to the next slide if you'd like there. Not much information on that. So I'll talk to you a little bit about my association. I work for the Ohio Healthcare Association, and we represent about 1,200 providers of long-term services and support in post-acute care in Ohio. What that encompasses is assisted living, home health, hospice, IDDD, which are intellectuals with developmental disabilities, and intermediate care facilities, and skilled nursing facilities. If you want to go to the next slide. So what exactly is advocacy? What do we actually do? We work with our state and federal partners to address regulations that make it difficult to operate or offer care and services to the people which we serve. So as part of that, we work with the Department of Health and Aging, Developmental Disabilities and Medicaid, the Board of Nursing when we can, and the Department of Education. And what we are trying to do with those efforts is to work with the administration to change their rules or laws in some cases that make it really difficult for us to operate and also to find workers. That's been a primary objective of our board for the last several years. Obviously, there is a healthcare worker crisis. We see that in a much larger scale in long-term services and supports, particularly because of COVID-19. In our industry, we lost about 14% of our workforce in skilled nursing and assisted living, and we've only regained about 4% of those. So we're at a deficit here. We also, if we can't, kind of reason with the departments, we use our advocacy connections with the legislature, representatives and senators in the state of Ohio, and the governor and the lieutenant governor to try to do common sense changes. And I'll talk about what some of those are. And occasionally, and what our topic of discussion today is going to be, we have to go all the way to federal regulators, and that's the Department of Labor sometimes, or CMS, or the Center for Medicare and Medicaid Services. Next slide, please. So again, we have lost a huge amount of people in our industry, and we were already projected at a deficit because of the silver tsunami. And that's what we call the generation that's approaching the 80-year-old mark and needing long-term services and supports healthcare. So, when you compare us to some other types of service lines like home health agencies, they lost, 9% reduction and a 5% increase in wages, where in a skilled nursing facility, we saw a 14% decrease in workers. That's a huge, huge exodus of people, right? And some of that was actually from people just leaving the workforce entirely. We'll go to the next slide. So what we've tried to do with our partners in regional workforce collaboratives, and I see a lot of familiar names as I work with some of you very closely, and working with the Health Collaborative in Southwest Ohio, is talking to our education partners to get to the root of the issue. Why don't we have enough nurses? It isn't that, we're not trying to hire people. It's not that we can't entice them. The wages that we are offering at this point in time are incredibly higher than what we were offering 4 years ago. It's really, when we get to the crux of the issue, that these people don't exist. We don't have enough. The shortage of nursing is in hospital systems, it's in dental offices, it's everywhere. So we're competing for the same people. And when you have agency coming in and kind of capitalizing on that situation, we're all at odds with each other. So what we decided to do is take our advocacy efforts and target them at education and work with our education partners to say, how can we help you get more nurses into your program and graduate more nurses into the state of Ohio? So we approached the Board of Nursing and asked to try to expand the instructor requirements to mirror other states and allow people who are RNs and on their way to obtaining a BSN to LPNs. They would not do that. So we went to the legislature and they did put that in statute. So that is something you can do now, is hire an RN who's on their way to becoming a BSN to teach your LPN courses if you're unable to obtain someone to teach an LPN class. Now, the Ohio Administrative Code has not been updated to reflect those changes because the Board of Nursing has to update that, and they will not do so until the rule review, but it is in statute. I'm going to go to the next slide. We've also worked to create a virtual nurse aid training option. So I'm not sure if you're aware of this, but if you have a STNA training course certified through the state of Ohio now, and you have a curriculum that's approved, you can do it online. You can do that virtually. You don't have to do anything different as long as it still has the same curriculum that you offer in person. If you are considering offering an online program and don't want to go through the trouble of recording and recruiting that, we can connect you with a program that already has that. And we have several universities in Ohio offering this program. It's called CNA Online. I'll tell you, I have a provider who utilizes this for his staff, and he has a 100% pass rate with CNA Online for those who take the NATCEP exam so far. He's only been operating it for 6 months. So I'm sure that that number is going to go down. But, to the point that Mike alluded to, when you give people flexibility of attending classwork within their own schedule, and you allow them to work in our provider area where we have providers doing the CNA training, they're able to do hands-on application of that education the day that they do the training. It kind of solidifies that education in their mind and has been very, very successful for the providers who have enacted this program. So we're really trying to find more creative ways and, again, reduce regulatory barriers so that we can offer training in the ways that best fit our students. And virtual training is something that was prohibited in Ohio until we changed the rules for that. If you want to go to the next slide. So we have upon us now an even bigger crisis. Of course, Centers for Medicare and Medicaid Services have imposed a minimum staffing mandate. This is proposed at this point in time for nursing facilities. And I want to start by saying that it is not our position that we don't feel that we need more workers in long-term care. We've been saying that for several years. It's that they don't exist. So mandating someone to have a certain amount of staff that aren't available is really only going to penalize the provider and limit the amount of beds available. Because what's going to happen is if they only have so many nurses on the floor, they're going to have to reduce how many beds they have, which is going to back up into the hospital. So this is a very serious situation. In Ohio, to give you an idea of how much staff we would need to meet the mandate that's being proposed, we would need 6,000 STNAs, 6,000. And we would need about 1,500 RNs. So it is a very, very high bar that they've set for us. I'm going to go to the next slide. And the reason why I'm talking about this is, regardless of how this ends up looking in the final rule, we are going to need more STNAs. And as we've spoken to our education partners, one thing that keeps coming up is, why can't you change the STNA instructor rules? So I want to explain this as succinctly as I can. This is a two-step problem. There are rules in Ohio at the state level that say that, it has to be a nurse who has had 1 year of long-term care experience, but that is actually a verbatim copy from the federal regulation. The federal regulation is set by CMS. Every year they go through a rulemaking process where they take comments on skilled nursing facility rules. And they're about to sit down here in January to decide what they're going to put in that proposed rule that comes out in May. So what we're proposing is to look at the federal language and propose something else. We recently met with CMS when we were at a HCBS conference back in August, and they said that they were willing to consider changes to this rule, which they have never said before. We've advocated for years for them to change this requirement. Right now, the requirement for instructors to change nurse aides, you have to be an RN with 2 years nursing experience and 1 year in long-term care. And what we find is that you can find an RN, but it's difficult to get one that has that long-term care experience. You want to go to the next slide. So Ohio, if you look at our language, it's really just taking the federal language and making it, mirroring it. And even if we change the language in Ohio, we have to go by the federal regulation first, and then the state regulation. So in Ohio, it says we have to have 2 years nursing, one of which must be in the provision of long-term care facility services. You want to go to the next slide? What we would like to change is just inserting an or. We would like it to be an RN who has a minimum of 2 years nursing experience, or an LPN with 2 years nursing experience, at least 1 year of which must be in the provision of long-term care facility services. Do I think CMS will do this? Absolutely not. But we might be able to get them to change it to be an RN BSN, or an RN with 2 years experience, with 1 year experience in long-term care. We have to start low and come to the middle with them when we make proposals on changes in regulation. And what we're hoping that does is open up the pool of people who are qualified to teach an STNA. In most cases, and you're looking at clinical practice setting, you're not looking at that much higher of a bar of what you're requiring for them to instruct and teach. If you think about a clinical care setting, supervisors are often the same exact certification as the person that they're teaching, they just have more experience. Those are some of our arguments behind why we think that they should be changing this regulation and opening up the amount of people who would be qualified to instruct. Go to the next slide. The state change is a lot more wordy. I'm not going to go out and read verbatim what the language change would be, but it honestly doesn't matter at this point. Because until we see what the federal language ends up being, if they will change it, we can't change the state language because it has to match what the federal requirement is. Go to the next slide. So how can you help? Because we know that right now CMS is considering making changes to this rule, you could contact CMS. I have put the information on these slides for how to write a letter to CMS. You address it to the administrator of CMS, which is Chiquita Bruxel-Sewer. She's not going to read it, but someone on her staff will read the comment. The discussions begin in January 2024, so that would be the best time to send a letter asking for changes to the CMS rules that are currently there. You can also contact your member of Congress, and I'm talking about your federal representative or senator. I put links to how to find who your representative is, but frankly, the more impactful and easiest way to make these changes would be to have CMS change it themselves. I'm going to go to the next slide. So what you want to put in that letter is just who you are and how this impacts you as an education provider. You know, how it impacts the workforce, difficulty that you have had filling the position for an STNA instructor change. I know some of you have reached out and we've had conversations about, you know, that you have an RN with a master's and they can't teach your STNAs because they don't have that long-term care facility experience. So sharing those personal accounts and stories, any data that you have on wait lists for because you don't have enough instructors to expand your class sizes, and then what you would like to change. We did provide the language for what you think the change should be, and you can just kind of put this in the middle of the letter. We think that the language should read this, and you put, you know, what you want the change to be. It doesn't, if you don't agree with what the change is that's suggested, put whatever change you do suggest. What's important is that every single letter is unique. CMS counts every letter and opinion as one opinion. But if we sent 100 draft form letters that have the same verbiage with just a different signature, that counts as one opinion. So we really need unique letters that would be written from individuals such as yourself, indicating how this would be impactful for you if they were to change this requirement. Next slide. What would not be helpful at this point in time, while the federal requirement remains in place as it is written, it does no good to reach out to the Department of Health or the governor or your state representatives because they can't do anything about it because of what the federal requirement is. So if we start, you know, knocking on the door of folks that really can't do anything, then when we do need their help after the federal requirements are changed, they're not going to listen to us. So it's really important we do this in the right order. And I see here in the chat, is there any consideration for the revision of the 1 year in long-term care? That's exactly what we are suggesting to revise, is to remove the year in long-term care requirement and just make it so that if you are an RN and you have 2 years nursing experience, you can teach an STNA. And if you are an LPN and you have 1 year of long-term care experience and 2 year nursing experience, then you can also teach an STNA. But it is to remove that long-term care piece if you are an RN. And that is, you know, RN, that's several steps above an STNA. They shouldn't have to need additional requirements in addition to being a registered nurse. But an LPN, which isn't as high up over an STNA and what they kind of learn in their knowledge level, they would need the additional training. And we think that that's a reasonable request for that kind of gap. If you want to go to the next slide. Okay, so that is my presentation. I'm trying to get through that as quick as I could. And if you have any questions, you know, please let me know if you have any discussion about this, or if there are other things that you think impede you as an educator on offering more slots or finding faculty or anything like that, that our association can help you with. We represent providers, but we are partners in education, and we really, really want to help you get more people into the workforce, because we feel like even though it helps every healthcare provider, it's the only way for us to really get more workers, is to put more workers in the workforce. Amy, you have your hand raised there.
Yeah, thanks. So I'm curious about something you said. We're a nonprofit organization in Cincinnati, and we have an STNA training program. And our challenge is around, you said something about educators are able to find RNs, but they cannot. Our challenge is we cannot find RNs who are, so I'm just curious if if other people on the call, or if that's their experience, if we're unique to that, so.
We have heard that from education partners as well, which is why we did both, right? So we removed, for the RN, we just removed the 1-year long-term care, but then we added an option for an LPN with 2 years nursing and 1 year long-term care, because then it addresses both problems. I hear from rural providers, a lot of rural providers, I can't find an RN, period. I hear from, more urban providers, I can't find an RN with long-term care experience. So I think depending where you are, the issue is different. And that's why we want to change the language this specific way so that it opens the door and addresses both issues. Does that make sense?
It does. It does.
Add some of what we're hearing is certainly the current shortage of RNs is creating an environment where any RN is able to make so much more working bedside than they can in instruction. It's created even more complicated problem than pre-pandemic. And these are the kind of points I think that if you're hearing it and it's impacting your work, would be important to incorporate into a letter to send off. As Erin said, every letter being unique and bringing it from your organization's view, you're going to help to open the eyes of CMS to just how this is playing out across the state. More than that, we're sharing this with friends also from the American Hospital Association that are in workforce across the country and encouraging them to also let their concerns be heard so that hopefully CMS gets a very holistic view of just how much this is feeding into the nursing crisis and into the healthcare crisis, healthcare workforce crisis.
There's a question in chat here from Melissa regarding the STNA protector testing, preceptor. The requirements make it difficult to find the test observers. Students have to travel far for testing. So we are actually addressing that as well. That is a Ohio Department of Health issue. They are the ones who designate the testing center. We would like them to open that up. They have a specific testing company that they utilize. But we have a lot of concerns with that related to English as a second language is another problem with that, and availability of test sites. So one thing I can tell you about that is OHCA does have a pending legislation amendment for workforce, and this is one thing that is addressed in that. And we plan to have that introduced in the House later this month. So hopefully we can actually get that changed. Any other questions? Okay.
Well, thank you, Erin. Erin does a great job. She's a wealth of information. So we really appreciate you sharing all of your knowledge with all of us. And she does it in a way where she explains it and it's easy for us to understand. So thank you again, Erin. As Hope mentioned earlier in our meeting, I'm Dr. Sarah DeLong. I'm the Associate Director for all the healthcare programs at Butler Tech. And we would like to start to hear from you to help us focus, where do you want us to advocate? Erin shared with all of you some things that we've worked on over the last year. And so this group really wants to make sure we're focusing on the right things. So we want to pick your brains and see what is important to this group. You are all the experts in the healthcare field in the state of Ohio. So we want to hear, where should our advocacy efforts be focused? So please share, even if you think it's an off the wall topic, please share with us because somebody else might be thinking the same thing. So we are going to use our Zoom whiteboard for this conversation. We did this in our first meeting for any of you that were part of that meeting. I'm going to go over just quickly some instructions just to refresh your brains. So once the whiteboard is on your screen, If you're on a computer, please move your mouse to the top of your screen and click on View Options. You can then click on Annotate in the drop-down menu. This will bring up a new toolbar for you to be able to participate and add thoughts to the board. If you're joining us from your phone, you can still participate safely. On the left side of your screen, you should see a pencil icon or 2 dots. Click on either one of those dots, and this should give you the toolbar. Once you have the new toolbar showing, you can click on the text option, then the screen to add a comment or click it or stamp to ditto a comment with a check mark, gold star, or a heart, your preference. If this is not working for you and you would simply prefer, feel free to enter your comments into the chat as well. So we have a couple questions that we're going to go present to you. And like I said, please be honest. And I think it's interesting in this group to be able to see all of our brains in one area and see kind of what topics are coming up. So the first question is, what topic, and this is a general question, we're going to funnel down to some more detailed questions, but what topic would you support advocacy efforts focusing on? So I know just in this meeting today, we talked about quite a few things. STNA, we talked about, Hope brought up pay for educators versus, you know, what they're getting paid out in the field. So anything that comes to your mind that you could see as an advocacy effort where we can advocate for your programming, your school, and see what changes we could help bring about. And you can let me know if it's not working. Let's see, keep an eye on the chat as well.
I'm dropping the instructions into chat too, just in case they're too fast. But as you said, first thing, if you're doing this on the computer, just go up to the view option at the top and hit on annotate. Also welcome to blurt things out, and we're happy to try and capture these too.
Is Michelle able to move those that are on top of each other? Awesome. And if you see a topic that you agree with, feel free to star that topic. So I'm seeing pay for educators, Ohio Board of Nursing constraints for clinical experiences. Would somebody be able to write in the chat a little bit more on that piece, the clinical restraints? Any efforts that address healthcare workforce shortages? More financial support for single working parents so they are not forced to work more. It's a good one. Work-based learning opportunities for high school students. More opportunities in outpatient facilities. Support nurses to best instructors, bridge programs. Stronger relationship with governor's office. Before I forget, I wanted to quickly bring up, so we have time for the rest of the questions, but have any of you run into the problem of hospital systems charging for students to have clinical experiences there?
We've had conversations with we've got a collective group that manages the clinical platform that we do with that matchmaking.
Mhm.
And some of the clinical platforms have fees for the
Yes.
students, and that's been a point of discussion. It's not in our primary platform, but there's been a secondary platform introduced because one of our health systems has a national presence, and they went with it system-wide. And that's a concern that the other ones had, is having to charge the students, the educators in particular, having to charge yet another student fee to
Mhm.
make their clinical matchmaking.
Yeah.
We're getting so much information on this. Again, if there's a chance that you can stop and take a look maybe and put stars next to one that are things you think are important, please do. And
That's great.
Michelle, I appreciate your efforts to keep moving these around. I know it's
Yeah.
really hard to do when multiple people are entering things.
So we will, as a group, will take these, this feedback, and we will, sift through them and see if we can, if it'll help, it will help us focus our advocacy efforts.
I'm interested in hearing what stronger relationships with the governor's office of workforce transformation looks like. Is that just a want of your area, or is there something in particular, to what end you're going for that?
So Hope, this is Sharon DeMario. That was me. I think that getting his ear, and we've had some recent discussions with one of his regional staffers around healthcare in general, could be really helpful. Our interest is obviously in behavioral health workforce shortage, but it is likely that he will be the Republican candidate for governor when in 2026, I guess, when DeWine is term limited. So I think any opportunities that we might have to build a relationship with him and really have him better understand some of the challenges that we're facing in healthcare workforce shortages would be really helpful. That's where I'm coming from. Does that make sense?
Yep, thank you.
Okay.
I think we're ready to move on to the next question, if the group's okay with that. So we got great feedback on the first question, which was what topic would support advocacy. So now we want to dive a little bit deeper into that. So based on the topic that you selected or you wrote on the whiteboard, what would be most helpful in lifting this for you and your organization? So when you're looking at that topic, what are the barriers that you're coming across, and what lifts, if you could lift those barriers and implement a solution to that problem, what would those lifts look like? That could be like resources, it could be additional knowledge in an area. So based on what you put previously, what does that support look like? Because if we can find supports for you in those areas, that's part of what this group's work would be as well. Sustainable initiatives. So for example, the previous slide, someone put instructor pay. We kind of all know what that is, but what would be a lift for that? Is that just funding? Is it relationships with, business partners in the healthcare field? Someone did mention work-based learning. What's an obstacle, especially at the high school level? What's an obstacle that you're having in implementing work-based learning for your high school students? Those are the things we're looking at. Students is trying to be edited. All right, thanks, Lisa.
Can I ask a question, Sarah?
Yeah,
the group?
sure.
As far as when you're talking about supports for people, healthcare workers, do you all, I've looked at introducing a bill for healthcare workers who are of a certain level, medical assistants, STNAs, dental assistants, kind of the entry level worker who have a lower amount of pay, being included in the child care voucher program, so that anybody who works in a healthcare industry and has one of these, I'll call them entry level credentials, would not have to pay for childcare.
Mm-hmm.
Do you guys feel like that would be an impactful thing? Because one thing that we run into with increasing wages for those positions are benefit cliffs.
Mm-hmm.
They lose their SNAP, they lose their daycare assistance. And so our thought was, well, give them a child care voucher program, then you're paying them more without them losing benefits. I see Shed.
I see a lot of heads nodding. Yeah, I would, I don't want to speak for the whole group, but I would say yes, that you're absolutely on target with that. Because you are right. It's that fine balance between making too much and then still not making enough to live. And that would be a huge, I think, enticement for people to stay in those jobs that are maybe lower paying. That's a huge benefit. Yeah.
I just want to say I see this every single day. So part of our work is not just training, but helping in our graduates transition seamlessly into work, but helping them retain that work. And so every single day we have our graduates who are working with our resource navigators on staff to help them access public and private resources who experience the benefit cliff daily. We're seeing literally rents, housing costs go up overnight, up to $500, $600, $700 a month because they're making, $1 to $2 more an hour, or they're taking on more. So it's a huge, I do a lot of work with the United Way here locally around this right now as part of their systemic change partnership. So yes, I think it would be hugely advantageous to advocate for these kinds of things for our healthcare workers. Sorry, it's a real passionate piece for me.
That's
So
okay.
No,
That's great. Yeah.
it's something that they did in Kentucky to help with the childcare problem. They didn't have daycare workers, and so they gave all the daycare workers free daycare.
Yeah.
And they filled all of their positions, all of them.
Just a quick chat comment, and then we'll go to the final last question. It said that it's in regards to clinical experience. The Ohio Board of Nursing requires clinical experiences across the lifespan, and it's become increasingly hard to secure sites. I agree with you. And instructors in specialty areas. Simulation is accepted, but not number of hours for clinical cannot be matched. I think that's a good point of conversation as well. So we'll be sure to talk about that as a group. These are great. So we're going to get to our last questions in honor of.
Sarah, I hate to interrupt you, and I think it's because we've had such phenomenal conversation. We're 1 minute to the close of the meeting. I have to save our last question to next time. I know we knew this might happen. So I hate to cut you off. I so appreciate you facilitating this conversation and everybody for the phenomenal input that you shared with us today. I put this in chat. Our next quarterly meeting will be on March 12th. The link to register, if you want to get that taken care of now so you don't miss it, is in the chat as well. We already have our first presenter, which it will be Great Oaks. They're at career campuses here in the Southwest Ohio region. They're doing phenomenal work in their health space. Their juniors and senior health programs allow their students, high school students, the opportunity to either pursue practical nursing or to earn up to 6 in-demand healthcare credentials before their graduation. We are still looking for another presenter to share and would definitely welcome any ideas you have, both to volunteer yourself or to volunteer others. We love that. And finally, I want to just share one thing. We had shared about the Ohio Board of Nursing proposed rule review in the Mobilize app. We are hearing that the Ohio Board of Nursing will be hearing comment on that proposed rule review potentially in their January meetings. They're going to be meeting both, I believe, Erin, it's the 24th and 25th. You
Yes.
need to request to be on that agenda. And it is Lisa, oh shoot, is her last name
Emmerich, Lisa Emmerich.
Emmerich, that you must email to ask to be on that. We'll include that contact information in the meeting notes. More than that, though, know that you can find Lisa's contact information on the Ohio Board of Nursing. If you are concerned about them changing the requirements of first-time pass rates for the NCLEX from 95% of the national average to 100% of the national average, a 5% increase. If you're concerned about that, I suggest that you get on their agenda and let them know why. Thank
I
you
would
again.
also say if you're not comfortable sharing that with them directly, and you want to share your argument with me, I will be on the agenda and be happy to pass that along.
Thank you. It's a great offer. I know sometimes worry about doing that themselves. So again, thank you so much for being with us here today and sharing your intel on advocacy. Hopefully you found the conversations valuable. We look forward to seeing you in March, and happy holidays to all of you. Have a great